mycotic aneurysm is from the vasa vasorum, bacteremia from the vasa vasorum, which is infecting the endocardial surface of the vessel, resulting in progressive fusiform mycotic aneurysm. Mycotic is a false name, pseudonym, because it is not a fungal infection. It is a bacterial infection from the vasa vasorum affecting the endocardium of a bigger vessel. You can see a typical mycotic aneurysm is intracerebral. This is a MCA territory mycotic aneurysm. So the phases of antibiotic therapy, initial 2 weeks is the early critical phase, IV only, no oral. After the second week, if there is no heart failure, no ongoing regurgitation, vegetation is less than 10 millimeter or it has disappeared, patient is not in failure or shock, and it is not staphylococcus or fungal infection, only then we can change it to oral OP, daycare based antibiotic therapy. So in the initial 2 weeks, we have to decide if the infected device need to be removed or surgery is required or abscess need to be drained. After that, it is continuation of the, so initial bactericidal phase is over. After the second week, we would have known if the antibiotic is treating or not. So we might decide if to continue the antibiotics as a outpatient therapy. But during change or at the day of 5th to 7th day during rejected endocarditis, at the 10th day of the critical phase, or during changing to outpatient, transesophageal echo is indicated before switching of the therapy. So there are two main classes of treatment. Empirical therapy before we get a culture. So that is only 2 categories. We'll see that first. And then once the culture reports have come, how we change the antibiotic, that is divided into 3 major categories based on the organism. So we'll see the empiric therapy first. So empiric therapy, we can divide it into 2 main categories. One is native valve endocarditis, that is community acquired bacteremia, or a prosthetic valve endocarditis, but more than 12 months, more than 1 year after prosthetic valve surgery. So this is a community acquired bacteria, the common bacteria. So the common bacteria being Streptococcus viridans or a staph epidermidis, coagulase negative staphylococcus. So we are dividing for empirical therapy only 2 classes. One is native valve endocarditis or prosthetic valve endocarditis after 12 months of the surgery. So 3 combinations. So both are A, C and G. First is ampicillin, second is ceftriaxone, gentamicin, or ampicillin, cloxacillin, flucloxacillin and gentamicin. So treatment is ACG for a community acquired native valve or a prosthetic valve after 12 months of surgery. Ampicillin, ceftriaxone and gentamicin, or ampicillin, cloxacillin with gentamicin. This is the initial empiric therapy until the culture reports come. The second group of people, that is prosthetic valve endocarditis, less than 12 months. So it is usually hospital acquired or healthcare associated. So what we have to expect, MRSA. The worst possible expectation is a MRSA. So treatment is 3. One is vancomycin, gentamicin, rifampicin. So vancomycin for MRSA plus genta and rifampicin because it is a prosthetic valve, gram negative and a fungal cover. So vancomycin, gentamicin, rifampicin, or if instead of vancomycin, daptomycin can be used.